I am Lori Chapo-Kroger from PANDORA.org and a member of the Let's Get It Right team. My health prevents me from being there with you today. First, let's address the elephant in the room. We are all concerned that this process will further set back patient care, and we are concerned that history will repeat itself and patients will end up in a worse position. In the real world, ME/CFS is used as a wastebasket diagnosis, and it's time to take us out of the wastebasket. The Let's Get It Right team is a group of advocates and organizations who set aside their differences and work to create a positive outcome in this IOM process. I was asked to address this question: what is the most important aspect or information that this committee should consider throughout the course of the study? My presentation and others in the Let's Get It Right team will tell you today some things to remember, but these are not comprehensive. This is a complex illness, so there are many problems that need to be addressed. Patients have poor clinical outcomes for many reasons. There are a number of clinical definitions, inaccurate cohorts, corrupt research, misapplied and harmful treatments, no FDA-approved drug, lack of physician education, and no medical specialty accepts us. The disease is under 2 ICD codes, leaving us with erroneous ICD data and has no widely accepted diagnostic biomarkers. And as we all know, it has a name that describes a symptom, not an illness. The main problem in the clinical setting of a fatigue-based definition is doctors confuse chronic fatigue with chronic fatigue syndrome. They diagnose patients with primary psychiatric disorders and not educated about illness severity and medical risk factors. They prescribe physical therapy and exercise that worsen patients' outcomes. They don't have specialists to send patients to, and they fail to diagnose the disease, and the public perception is incorrect. There are many case definitions, with some being very broad, where the only criteria for diagnosing chronic fatigue syndrome is 6 months of fatigue, and others like the Canadian consensus criteria that are concise and capture the true illness. But the multiple definitions and the overly broad definitions are causing clinician and researcher confusion. When looking at research in your study, we recommend you reject all research that focuses on or only requires chronic fatigue. Those studies do not inform you on our illness. They inform you on a symptom of many diseases. Some of you may think that a broad definition would be better for patients because a more focused definition would limit treatment. This isn't true with ME/CFS because some of the treatments that are prescribed for idiopathic fatigue are harmful to patients. For example, someone who has depression should be exercising more to release endorphins, but someone with ME/CFS will need to be careful to pace and not exacerbate symptoms by exercising. However, be careful that it isn't so narrow that patients are told they have idiopathic fatigue when they actually have our disease. Subgroups can be helpful in distinguishing those with the disease who need individualized treatment plans. And on slide 5, fatigue is the 7th most common symptom reported to doctors. Fatigue is subjective. It also is experienced by healthy people, and fatigue can result from virtually every physical or psychological illness. On slide 6, this is what we need you to do. We need you to create a definition for our disease that distinguishes ME from primary depression, idiopathic fatigue, and other organic diseases. Why? Because we want the right treatment, not the wrong treatment. We need a definition narrower than Fukuda and Oxford to eliminate idiopathic fatigue and primary depression, but balanced enough to include those patients that represent the proper cohort. Notice that ME and all of those circles with ME is with post-exertional neuroimmune exhaustion. It is separated from those with chronic fatigue and other symptoms, and it has subgroups. All of these conditions are not under one big chronic fatigue umbrella because fatigue is a symptom of many diseases. While depression can be comorbid, each of these diseases need to be easily distinguishable, preferably by an objective test, so we all get the right treatment. A concise definition for ME, and this is on slide 7. The main thing that has to happen in a long chain of events to get this right and to significantly improve patient care and quality of life. Everything else will change as a result of having an accurate definition. The case definition drives proper diagnosis. This is the most important sentence in my whole thing. The IOM study is important because until we have a universally accepted biomarker, the clinical definition will be the frontline diagnostic tool that determines the course of clinical care and treatment management for patients with ME. There is research that points to biomarkers. The case definition drives proper coding. For 2 years, our organization and the Coalition for ME/CFS worked to solve the coding errors in ICD-9-CM. But until the disease is better identified by an accurate definition, we will not see consensus on what category or code it should have. More details will be covered in Pat LaRosa's presentation. The case definition drives drug company interest in FDA standards for clinical trials. In a presentation to the FDA, or to the Federal Chronic Fatigue Advisory Committee, Rear Admiral Sandra Creeder from the FDA said that in order for pharmaceutical companies to invest in developing a treatment, there first has to be accepted definitions and outcome measures. Pharma and biomed are dependent on a good case definition to identify patients and the effectiveness of their treatments. The case definition drives better disability assessment. Right now, waiting 6 months for diagnosis and lacking objective measures of severity means patients must fight years for the rightful benefit, and some are never approved. The case definition will lead to a proper name and more research, and a proper name will reduce confusion and lead to public understanding and family support. If you get it right, you will fix much of the problems with this disease, and I and millions of others can live better and healthier lives. So let's get it right. Thank you.
Thank you very much, Ms. Chapo-Kroger. Are there any committee members who have further questions that they would like to ask you? Well, thank you very much. That was really very helpful, and I appreciate your taking the time both to speak with us and to create the slides ahead of time, because that really helps frame your thoughts in a way that's very accessible to us. So thank you very much.
You're welcome. My pleasure.
Well, it's really important, so thanks. Our next speaker is here, I believe, Carol Head from CFIDS Association of America.